I'm Dr. Konrad Schargel, Glaucoma Division Chairman, and I'm in charge of giving the super specialty lecture on visual field and OCT and some other tests that are important in the glaucoma management. These are more or less the four areas that I pretend to talk about. And if you allow me at the beginning, I'm gonna go for some glaucoma concept in general. Just remember that glaucoma is defined as a damage of the optic nerve with an expression in the nerve, retina nerve fiber layer lost, and with the corresponding visual field effect. So that's why these two key tests are so important in the diagnosis, control, and management of the glaucoma disease. If we analyze this nice, probably has more than 10 years, schedule that was designed by Weinreb on glaucoma continuous, more or less 2/3 of the disease do not have any symptom. And finding the defects in the nerve fiber layer in the optic nerve and in the visual field takes a long time, and we need that the disease advance quite a lot. So it's very important to be very careful and explore everything carefully. The classification of the glaucoma, we know open angle, close angle, primary and secondary. According to these, there are some tests that are going to be more helpful than others. And the presentation of the patients in our hospital, mainly primary angle closer glaucoma by 30% of the cases, followed by primary open angle glaucoma, and then cellular exfoliation and other ones. I will take a time to do some reflections on testing glaucoma. If we go back to our medical school, there is not much difference between the health history and the ophthalmological history. We could say that we could merge all of this way that we have been trained to find all the clinical signs in our patients. And it's very important that we keep in mind that before being a super specialist, we are ophthalmologists. And before being ophthalmologists, we are physicians. So we have to think as the whole of this. It is not worth it to have a retina flat apply after a wonderful surgery, but our patient ran blind because we didn't measure the pressure. In general, we are like in this nice TV show that I don't know if it was popular here in Saudi Arabia, but in Europe and North America was very popular. Crime Scene Investigation, CSI. We have to learn how to get all of our hypotheses based on clinical findings and criteria and cluster all of the pieces together. And the pieces must match in order to have a proper diagnosis of the disease. And if it doesn't match, we have to discard some of those pathology or some of those hypotheses that we had previously. And to test for those that attend to one of my lectures about 2 months back, which one is the most important test for glaucoma management out of all of this? Write it down in a paper and let's see. The most important glaucoma test for the management is the best corrected visual acuity. And I'm going to show you one scenario. This is our patient. It's a male patient, 61 years old, diabetes, high blood pressure, known having glaucoma on medication. A scenario 1, no light perception in right eye, pressure high, cataract, no view from the fundus. A scenario 2, exactly the same, but one difference. Best corrected visual acuity is 2200. If this patient has pain in the right eye with no light perception, the treatment is not even done by the glaucoma specialist. It's done by oculoplastic, a retrobulbar injection. So for management, the most important test is how is the vision, the best vision in that patient. Another test that is important is about refraction. Why refraction is important? First, because it gives us the idea of the best vision this patient can get. Second, because it gives us the differences between the eyes, tell us about the presbyopia. Also, some types of glaucoma are related more to myopic, some others to hyperopic eyes, and the astigmatism will affect our measurements of the intraocular pressure. And of course, the best result for the visual field will depend on how good the refraction has been done. And the value of refraction, and here I give you another example, chronic angle closer glaucoma, trabeculectomy done in the right eye, FEBO done also in the right eye, vision 20/160 in that eye, and this patient is booked for cataract surgery. The refraction done in the first eye, which is the right eye, was plano with a very tiny astigmatism. And the refraction in the left eye is -4. If this patient has a chronic angle closer glaucoma, myopia doesn't match with chronic angle closer glaucoma usually. Of course, there are exceptions, but this is not the rule. So we can use the IOL calculation to know that in the left eye, it's not a myopic eye. It's a 21.26 millimeters of axial length. If this eye had -4, a real -4 axis myopia, the axial length should be around 25. So this patient has a chronic angle glaucoma because he has a short eye, and probably the reason of this myopic shift is a cataract. And just as a cultural back, this is the way the famous Dr. Barraker did the surgeries in the 1950s. This is the von Graf knife, and the best surgeons were the ones able to do one incision in one movement. This is done with topical anesthesia. So when you think about giving a peribulbar and you need a frozen eye, remember about Dr. Barraquera able to do an intracapsular cataract extraction on a moving eye, just with a cryo-extractor like this, and halas. So let's go back to the diagnosis of the glaucoma. Here we have all the tests that I'm gonna try to talk in. No, I'm not gonna talk about all of this, it's too much. Remember that the diagnosis of glaucoma depends on many things, but the most important test to diagnose the glaucoma, as the definition that I showed you at the beginning, is how the optic nerve is. The structural and functional test, mainly what we do is the observation of the nerve fiber layer. Even if we describe only the cupping, we must see the nerve fiber layer. And here you can see that there are a notch, and also here there is a lack. When you compare between the superior and the inferior part, you can see that here you have a lot of nerve fiber layer, which are not here. Well, basically this, that is a qualitative evaluation that I just did based on a red-free photograph. It's what the OCT does. Remember that when we talk about OCT, not all the machines are the same. And each machine is going to be, each brand is going to be purchased that they have the best machine, the most reliable, they are able to detect the smallest gap between. The important thing, for example, comparing all of this equipment when they were analyzing the ganglion cells in the macular area, it seems that there is an 8 microns glaucoma gap, which is the measurement able to be measured to detect the ganglion cells. Let's get into the interpretation of the OCT. That probably this is the useful thing. I'm gonna use this size test, but most of the machines present the results in the same way. As you can see, the results are in Spanish because I like that language, first of all, and the second is because the quality of the pictures was very good. These are patients that I had it before. So the first thing on interpretation of the OCT is signal strength. The signal strength is the intensity signal that each machine has their own parameters. So look for the quality in this intensity of the signal. The second parameter that we should check is the nerve fiber layer thickness map. This is an entire acquisition. You will see it right away. It has like a butterfly wing shape, and it shows in red and yellow, as you can see in the color bar next to it. The hotter the color is, the thicker the nerve fiber layer is also is. It's very important to detect the asymmetry between the superior and the inferior. And here you can see this wedge or notch that is blue. This means there is a thinnery in the nerve fiber layer. The retinal nerve fiber layer thickness deviation map is the area in which these defects are going to be comparing with the normal value. Remember that the normal value, the database in which is compared, depends on each machine. The larger the database, the more accurate the machine will be. The points that are usually situated outside the confidence interval are defined by this red and yellow color. So in this map of deviation, it's very important that we think this is the opposite to the full retina nerve fiber layer map, the superior one. Here, the red and yellow show the thickness, and here the red and yellow show where is the defect comparing with the normal values. This area, it's in charge of detect abnormalities that are usually situated at this limit. This limit is around 3.4 millimeters away, and its work is considered that the thickness of the nerve fiber layer is more reliable. The nerve fiber layer thickness measured in all A scan of the peripapillary circle is in this area, and after merging all the results, it's when the graph of the temporal, superior, nasal, inferior, and temporal, the TS-NIT graph, will present this double hump measurement and will tell us mainly on color code distribution, the normal values and where each eye is situated. It also helps us, like in this case, to detect where are the notch, or in cases of tilt optic disc, the flattening position. Remember that the eyes here and the database here, it's based on average of the population. So extremes defects like high myopia, high hyperopia will not be able to be analyzed on the database. The TS-NIT graph of the neuroretinal rim is the other graph. It takes the measurement from the opening of the Bruch membrane. Some machines, like for example, Spectralis, you are able to manually change that position of the Bruch membrane, and this gives you the perspective of usefulness, especially in high myopias. Also use the same color code distribution, comparing with the normal values of the and comparing the age of the subject with the normal database. And also try to look for defects and extensive notch. Then we have the areas of the enlarged horizontal and vertical B scans that are these two squares that you can see here with the horizontal and vertical. It helps us to detect where is the opening of the Bruch membrane, that is right here. It also have the define of the surface of the limiting membrane here in a red line. The mean retina nerve fiber layer thickness value, particular attention is this two graph right here. We must pay particular attention to the superior and inferior quadrants, like in this case. Remember that in glaucoma, or in general in ophthalmology, but specifically in glaucoma, asymmetry between one area and the other area are suggestive of being a pathological change. Also, the two contiguous meridians, it's very important. Like these two will form the whole superior quadrant. There is one thing that we call the red cheese syndrome. That is like in this case, be careful. This should match, as we were saying, this is only a test. It should match the clinical picture of the patient. First, observe the optic nerve, then goes to the OCT. The color code representation also compares with the database. You can have the values, but mainly this color code said that the red is below the average, green is on the average, and yellow is borderline. And then finally, the last two areas are the circular B scan extracted from the optic nerve cube, as well as the internal and external limits of the retinal nerve fiber layer. And this is used as a qualitative measurement to see if the segmentation, the alignment, the centering of the test has been done properly. What we should also look in the OCT. Well, it's very important to look for the quality of the signal, for example, like in this one, all right? It gives you the color green, means that the quality is good. So over 6, 7, the quality usually is good. Under that one, the quality is not that good. And it could depends on different factors. We analyze also the ganglion cells in the macula, and when you see the green colors, it gives you the idea of the average of the normality. It's very important that we also take a look to the proper alignment of the limitant membrane of the retina and the profile of the fovea. This is a test for glaucoma. So we'll analyze mainly the ganglion cells, will not analyze edemas, but you can see if there is a change of morphology in the fovea or in the macular area in general. And you could do a program specifically for the control and check of the macular area and the edema. Always check the signal. And if the signals are not good, we must try to look what was the case. For example, in the right eye here, there is a blinking, and you can see this line. The problem with the test is the idea of doing or ordering any test is to help you to eliminate from the diagnosis that you had in your mind. You must have about 3 or 4 of the possible diagnoses. Test must help you to discard those that are not useful and to keep the ones that are strongly supported by the test. But if the test is confusing, like it could be any of this OCT visual field, then it's not going to help you. So be careful when you analyze the test in order to be an assistant, a help, and not the contrary. Like in this case of the macula, you can see that the test is not done well at all. The signal is very low. The alignment in the limiting membrane is totally out of the area. And this should be repeated or at least not given to you, because this is going to confuse more than help. When we check also the interpretation of the OCT, and this is one of the largest and most important that Nahid, do you have your microphones on? That will be good. Anyways, so the great bet of brands like Zeiss is to put in a platform like this Glaucoma Forum is called, the results of the visual field against the results of the OCT. And the good thing is that you can have the defects of the visual field and check that it matches the corresponding defect of the nerve fiber layer captured by the OCT. So really, in these cases, they make the fusion between the two tests and giving you the platform. It will give you the idea of the defect and also the progression. There are two other new technology, which is the enhanced depth imaging and the swept source. The main point in these new technologies or new generation of OCT machines is that we are able to study the choroid. And by studying the flow in the choroid, it seems that decreasing flows in the choroids are also one of the earliest signs of the glaucoma. And it could be also a prognostic factor in the glaucoma progression. So let's get into the visual field. A little bit of history. Here you have us from Graffe. From Graffe, it was one of the guys that he dies very young, but he creates a lot of things, including that knife that you saw in the surgery that I show you. Here you have Pierum, that is the one that describes the arciform escotomas. Rune, that it was the one that described the isopters. Goldmann with the famous bowl perimetry. And then we have the static perimetry that are the earliest automatic perimetry described by these two gentlemen. So basically what the visual field does is detect the function from the ganglion cells and the nerve fiber layer. When we talk about the glaucoma hemifield test, what it does is comparing these 5 mirror area in the superior part against the inferior part. As I said before, the symmetry is very important in glaucoma. The strategies we're going to use, and we will talk a little bit more about this, are based, if we talk about the threshold strategies, is what we call the 4-2-1. It means that the stimulus has 4 decibelius and it's reduced 2 by 2 and then increasing 1-1 in order to detect the minimum stimulus able to be detected and build this island of vision in the ocean of darkness described by Tranquil. And the strategies like Zeta fast and Zeta standard, what they did is trying to short this stimulus progression. Remember, when you analyze the visual field, that is not only dependent on the nerve fiber layer, it also depends on the pathology that you might find in the retina. So first look the eye and then request the test. Never do it in the other way around. You must have a nice retina, at least with the defect that will match the defects you will find in the visual field. And here we have a large variety of all the strategies and that we can have in the Humphrey visual field. I'm just going to mention some of them, the one that we usually use more often. And this is one way of analyze the visual field that I found in a publication of Abdel Shafiq, which I think is great. It's a memotechnic technique, wonder as what was done, accuracy of what was done, look for normal or abnormally. Any defect pattern presented must be matched with the pathology that you are looking for. Evaluate the compatible disease that match this defect pattern and review the literature for some differential diagnosis according to what you found. So remember that not all the pathologies that affect the visual field are mainly glaucoma. There are some other neurological things also involved. So when you are checking the visual field that you request, well, the important thing is which test area was evaluated. Rarely we use the 60 degrees, that is for neurological condition, most of it. In 30, 24, and 10 degrees, you get all the information you need for evaluation of the glaucoma. And the strategies, the most important thing about strategies is you have to put in the balance the duration of the test against the information you want to get. And this is how we have in streams, in the superior part, the longest and probably more information you can get is the threshold, but it's really tiring. And the screening is very short, is seen, not seen strategy. So it's very short. It can give you an idea, but it's not useful for glaucoma diagnosis or glaucoma progression control. So the strategies in Humphrey is CETA fast or CETA standard. CETA fast reduce it and you lost some of the information, but reduce the test a lot. So always when you think about requesting a visual field, see your patient. Patients that have problems to be remaining sitting for 5 to 7 minutes, they are not suitable for visual field. Patients that have problems with the neck that cannot get the right position, or they cannot keep concentrated on the test, don't request a test that needs at least 5 to 7 minutes of concentration. So these are the parts of the Humphrey, which is quite similar to the octopus, but we don't have the octopus here. So we are going to talk about Humphrey mainly. Reliability indices, strategy use, gray scale, numerical values, parent deviation, the probability plot graph, glaucoma field test, and some global indices. So when we talk about reliability indices, mainly are fixation loss, false positive, false negative. There is also the tracking of the vision down. It is cut in this test, but it is down. And the short-term fluctuation usually now is not when you request the CETA fast strategy or CETA standard. So basically here you have the reliability indices, and they are usually flagged when they exceed the 33%. Check how all in these indices you have here the test duration. This is always a good thing to check. How long took between one eye and another, because it gives you an idea of how heavy this test could be for a specific patient. So fixation losses is the number of times the patient responds to a target placed in the blind spot. The blind spot is the first area that was detected at the beginning of the test. I don't know if any one of you have done a visual field. If not, it will be a great exercise, and then you are going to feel pity every time that you request a visual field, but it will give you an idea of what this test is. So fixation loss, usually if a patient has a very large defect that it's affecting the blind spot, as this area will be enlarged, the fixation loss rate can be very low, even if the patient was not seen in the proper area. The false positive error is the number of times that the patient will respond to an audible click of the machine. It means the machine, every time that produces the stimulus, have a sound, and the machine is quite smart. So sometimes it produces this sound without producing the stimulus. And this is what, if the patient presses, this is what it is, the false positive error. The false negative error is the number of times that the patient fails to respond to a supra-threshold stimulus that in an area that it was already detected as a seeing area. So, and a stimulus that the patient should see, but it doesn't report as seeing, it's what is a false negative error. And usually it's an indicator of fatigue in this case. Usually, if there is a high false negative error, the visual field will show a worse appearance. So always check the duration of the test, because it will give you a clue of how intense has been the test. So grayscales. The grayscale is something that we don't use to analyze the test. Depending on the area that you explore, if it's a 24-2, you will explore 54 points. If it's a 30-2, it will explore 76 points. The grayscale is usually used for showing to the patient the defect, the magnitude of the defect. Usually the spaces are filled, so that's why I give you this map of black and gray. Then we have the numerical printout. The numerical printouts are the sensitivity that each area has. And this is what you can use, but it's time consuming to evaluate the severity or the progression of the visual field defect. in this situation, it's more important cluster of dots that a single dot. What I mean is, if there is a decrease in sensibility in 2 or 3 areas of 5 decibelius, it's more important that a single dot with a decreased sensibility of 10 decibelius, because one point will confirm the other one, the neighbor. The total deviation is the difference between the area measured and the individual test location with the age corrected. That's why the first part of this test, the Humphrey visual field, will not start if you are not setting the date of birth correctly, because all of this statistical analysis will depend on the age of the patient. It will compare the normal values of each test location with the normal persons of the same age. So it means that if you have a presentation of a -5, it means that the sensitivity for that area in our patient is about 5 decibelius below the normal for the same age group. If it's +3, it will be that is higher. It is a high sensitivity comparing with the normal, and if the value is 0, it means that it's the same that the normal population. The probabilities plot, what it does is give you in a black gray dot presentation the distribution according to how frequent is among the population. And remember that the p-value doesn't mean that the field is pathologic. It only indicates that in that specific area, the field has a deviation according to the age-adjusted normal value. Usually, total deviation, if it has a general, the pressure is usually observed in cataract and miosis. But also could be an initial sign of generalized loss of retina sensitivity, which it can also happen as an early sign of glaucoma. So we have to be careful on that interpretation. The pattern deviation is the difference between the adjusted threshold of each individual test location and the age-corrected normal value for that position. It comes from a total deviation, be a special adjustment of the measurement of the threshold, that it could be adjusted upwards and downwards according to the response of the patient. And this adjusting sensitivity is also compared with the normal value of according to the age. So with this, what this pattern deviation does is remove the effect that it could be produced by a generalized media opacity. The global index, we have the mean deviation, that is like any mean, is the average difference of each test location against the corresponding normal values for the age. The pattern standard deviation is the standard deviation calculated from the difference of each of these test location. And then you have the short-term fluctuation, which is not presented in the updates of the Humphrey evaluation, but it's a variability of the threshold. You have a new index, that is the visual field index. I will show you later on what it means. Then we have the glaucoma hemifield test, and here, as I showed you in the previous slide, it compares 5 areas in the superior against 5 areas in the inferior. And it will present, it is also only works for glaucoma. Neurological condition, the glaucoma hemifield test is not useful, and it has these 5 possible presentation: outside normal limits, borderline, generalized reduction in sensitivity, abnormality, high sensitivity, or within normal limits. The visual field index, what it does is give different value, because the areas in the retina doesn't have the same sensitivity. For example, the closest to the macula in the 10 degrees of the central vision is more sensitive to the light. So those points will have a higher value. And as we get away into the peripheral area, this sensitivity decrease, and then the value that we'll have for the mean arithmetic mean of this index, it will be less. And the important condition in the visual field index is that it's used in a specific new program that the new has about 6 years, that the Humphrey analyzer has, that is the glaucoma progression analysis. And this, what it does is compare all the tests done by the patient in a timeline and set how is the deterioration in the visual field. It also gives you the rate, the progression rate, and the points that has been changing comparing one test to another. So it's a very valuable analysis for progression in glaucoma. The important thing, according to the GPA, is that all the tests must be the same. It means all has to be done with the same strategy. For example, CT standard or CT fast. You cannot exchange CT fast and CT standard. It must be the same strategy always. So the defect of visual fields can be, in general, generalized depression, paracentral scotoma, arcuate scotoma or Vieron scotoma, nasal step, altitudinal defect, and temporal wedge. Mainly, these are paracentral scotomas that once they join all together, they form an arciform scotoma or Vieron scotoma, in this case in the superior area. And the progression will go with the same arciform scotoma in the inferior area, which will join together and will form the annular scotoma of Rune. And this is the tunnel vision that we all know. And when we progress to the largest defect, then we have this tunnel vision and the remnant of the temporal island. Remember that symmetric defects that will not pass the mean line usually are not glaucoma. Usually these are neurological conditions. And as I mentioned in this third slide, during our evaluation, we always have to keep in mind life threat conditions, and one of them are the neurological condition. A little bit of Goldmann visual field. Basically, what the Goldmann visual field does is you try to build all the points that has the same sensibility in one area. This is called isopters, and the isopters at the end give you this shape that is the island of vision described by Tranquer in the 19th century, with the deep volcano hole that is the blind spot, as you can see here. This sensibility has this index in Roman numbers and in Arabic numbers. And the defect that you can find is, for example, the visual field grade 1, it will be an exclusion of the blind spot, as you can see here. This is an early sign of glaucoma. Or you can have a visual field grade 2, which is a deficit in one of the quadrants. Okay, this resembles the ring scotoma or the nasal exclusion. Or the visual field grade 3, in which you have this central terminal remains, that is the tubular vision, the tunnel vision. The issue with the Goldmann tonometer is that, as you can imagine, the evaluation of the fixation or cooperation of the patient, it's a qualitative way. It means technician will say, well, the patient has a poor fixation, so you know that you can rely or you can trust according to an evaluation done by a third party, in this case, the technician. What other tests can be useful in glaucoma? Well, we can use UBM, especially in conditions in which you want to have an evaluation of the anterior segment, let's say non-ophthalmic eye, or in cases in which the opacity of the media doesn't allow you to do a proper gonioscopy. Remember that the gonioscopy will give you some ideas, not only on if the angle is open or closed, but it will give you also idea on pigmentation, neovascularization, signs of inflammation. The B scan, it's very important, especially in similar condition. Congenital glaucoma is a way to follow the patients by axial length measurement every now and then, and also to know the condition of the retina in cases in which you are not able to see through the clarity of the cornea. Also the thickening of the wall in, for example, patients that have non-ophthalmics eye are important parameters. Remember that when you request a UBM or you request a B scan in a patient that has a recently surgery, especially a glaucoma surgery, in which what we have done is a fistula, it's an opening of the inside part of the eye and a communication with the exterior part, this must be gentle because you can push all the aqueous humor out just by doing one of these tests, because they need that the probe be in touch with the tissues of the eye. Anterior segment OCT are very useful now and give a very high quality test. You can see in this non-ophthalmic eye, after we remove the cataract in here, how the anterior chamber becomes deeper, even if the angle remains close, as you can see in these areas here. Also, the anterior segment OCT can be an excellent tool to make an evaluation of our filtration surgery. In this case, is a deep sclerectomy with an implant, non-absorbable implant that you can see it here. This is the snopper implant that goes into the suprachoroidal pocket. So, and here you can see even the trabecular measure window, that it was perfect. So in case that you need to do a gonio puncture, this is the area that you have to shot. And also you can have a control of this with the anterior segment OCT. Remember that the endothelial cell count are very important, not only in cataract surgery or corneal pathology, but if a patient has a tube in anterior chamber, not only by physical touching of the tube against the endothelial cells, but also because of the currents that are produced at the tip of the tube, it can be a decrease of endothelial cell count, and that could be a reason why you should change the position of that tube. Few words, these are the last slides, I think. There are, nowadays, one of the important things are the biomechanical properties of the cornea. There are some equipments that can give us not only the pachymetry of that cornea, but also index of corrected pressure according to the thickness of this cornea. But not only the thickness is important, it's also very important how is the plasticity and the viscosity of the cornea. So instruments that are used for example, keratoconus and to measure after treatments to make that cornea stiff will affect the response to the pressure. And now we can have glaucoma screening factors like biomechanical glaucoma factor that will indicate the risk of having normal tension glaucoma against ocular hypertension or primary open-angle glaucoma. It's also a very valuable information in some of our cases. To finalize, well, what are the most important tests according to the glaucoma societies? Well, the European Glaucoma Society said that the recommended test at the first assessment of a glaucoma patient with a strong evidence will be best corrected visual acuity, slit lamp examination, gonioscopy, tonometry, visual field, and optic nerve head and nerve fiber layer evaluation. And with weak support, central corneal thickness and OCT. And if the patient is going to be monitoring, the recommended test will be also best corrected visual acuity, visual field with software-based progression analysis like the GPA, clinical examination of the optic nerve head. Always you have to look at the optic nerve head, and the tonometry. And with support, OCT with progression analysis and the gonioscopy. Gonioscopy, once done, usually the angle changed very little. So remember, the important thing is the quality of the test more than the quantity of the test that you do. So always check for quality conditions and the index of high quality. If it's not well done, it's better to repeat or discard the test. Thank you very much. So if there is any question, I will try to answer. I don't know, but I will try to answer.
Hi, Dr. Konrad.
Hi, Dr. Ayman. It's nice to hear you. How are you?
Good. How about you?
Good, good. Thank you. Tell me,
you
have a question?
Workup. Regarding annual workup for a patient, other than the visual field, you do OCT? Or...
say it again, sorry?
For the annual workup for a patient, follow-up.
Okay.
For example, like an open angle glaucoma, other than the visual field, do you do also OCT or no?
That's a very good question, Ayman. You know, I think that you have to divide the test probably for documentation purposes and for diagnosis and for progression follow-up of a patient. So what I do in the clinic for documentation purposes, I always request a fundus photo, because the description of my optic nerve and the capping and the nerve fiber layer that I probably will write on the file will probably be close, but never the same to another consultant. So if someone is going to analyze that optic nerve, it will be good to have a visual reference like a photo. Then OCT is a good parameter because it's usually not patient dependent. Most of the patients are going to be able to resist the whole test, you know, and it will give you a perspective of how is the nerve fiber layer. Then the visual field. Visual field we request a lot because it's very important, as you could see in the last two slides of the presentation, are strongly support as tests that we should request in all of our glaucoma cases, but has some limitation, important limitation. Patients dependent. So if you wanna, I always request the visual field after seeing the patient. If I see that the patient has some mobility issues, neck issues, arthritis, complaints of back pain, or it takes a while to understand some of the simple things, it's better to talk to the technician that is going to do the Goldmann visual field, if she's going to be able to do it, or avoid the visual field. That's my perspective. But if the patient can do the test, for me, it's the most important. Visual field, it's what it's going to give you the real idea of how is the condition of the patient. So once you determine which are the tests you were able to do, you have to stick on those tests for the progression of the patient. I don't know if I answered your question.
Yes, you did. Thank you so much. Very clear. Thank you.
My pleasure. Thank you.